At Mahajan Medical Center, we care to listen to our patients. Proudly serving the needs of Tampa Bay in primary care for 25 years and counting. So let's get started on the COVID journey with you, Lalit. So here's our first slide. It's a beautiful, very pretty virus, but very deceptive. You know,
Yeah, COVID, the virus is actually SARS-CoV-2. It came from the severe acute adult respiratory syndrome back in 2002, when it was the first time this was diagnosed, and this was found to be epidemic in the China side, I think. And since then, there are multiple mutations has happened from the SARS-CoV to MERS, and then now COVID-19. COVID-19 actually is a term. If you break it down, CO is for coronavirus, VI is the virus, and D is the disease. So coronavirus disease, and because it was identified in 2019, it is called COVID-19. It has a crown-like spikes, and that's why it's called coronavirus. And you will be surprised that we have coronaviruses around since 1960s. We never bothered about them because the disease they caused was very mild, just like a common cold. And there are like 4 viruses which are prevalent in the community, which are the common human coronaviruses. When the animal coronaviruses jump to the humans, they cause problem. MERS-CoV, SARS-CoV, and SARS-CoV-2, these are all viruses which jump from bat to the humans through an intermediate host. As you see in this slide, in 2002, civet was the intermediate host, and it jumped into the humans, and we saw at that time, it was very deadly. It had like 40% mortality. We didn't have cure for that, but because it was limited to one part of the world, we didn't talk about it much later on. Same thing happened in 2012 when in Middle East the same coronavirus jumped from bat to camel and camel to human, and at that time we saw again Middle East respiratory syndrome. That was the name of the disease, and because it was again limited to one area, we didn't talk about it much at that time. Now, 7 years later, coronavirus jumped from the bat to the pangolin, and pangolin to the humans. Pangolin is an animal which actually has some importance of these scales used in some treatment forms in the China area. And you see, it's a beautiful animal, and people pet them. So one theory is that came through this pangolin, and the other theory is it came through the wet market, when the meat was sold. So we still think it is a natural jump from bat to pangolin and pangolin to humans. They have a tendency to mutate, and they keep on mutating as the time goes, as they jump from host to host, as they replicate. Now, it is important to understand what is this coronavirus structure is like, because that is the essential part of our finding a treatment, finding a vaccination, and how to prevent it from happening further, spreading it further.
We get a lot of these questions. I'm pretty sure you get it too, Lalit, that I just got COVID. I finished with my infection. When should I get the vaccine? What I read, and correct me if I'm wrong, the CDC recommend once you finish with your quarantine and you're not transmissible at that point, you can go ahead and get the vaccine safely.
So if you got the COVID and you did not have much symptoms, you did not require the monoclonal antibody, you did not require the hospitalization with convalescent plasma, then you should be able to get the vaccination immediately as you finish the quarantine period. COVID infection itself is not a contraindication to get the vaccination.
Right. So, and a lot of patients ask me, I'm going to have antibodies since I got infected. What's the rationale? And my understanding, and correct me if I'm wrong, is that you have to hit a jackpot with COVID-19 to get the neutralizing antibodies. You will get antibodies, the IgG, IgM will go up, but that does not mean those are the blocking or the neutralizing antibodies. With vaccination, they are designed against spike protein. They're designed to give you longer lasting neutralizing antibodies. Is my assumption correct, Lalit?
Yes, you are correct. Basically, if you got COVID, depending on your severity of infection, suppose you got a asymptomatic infection, or suppose you were in ICU, there will be a different level of antibody response in your body. Asymptomatic infection will not produce that much antibody in your system. In a patient who has a severe infection will have more antibody titers. So will there be neutralizing titers in a patient who had asymptomatic infection? It's a questionable, and we do not know the answer to that. So because of its so much variable response in different people, we want a kind of consistent response with a standard dose of vaccination, so that all humans are at the same level, and to get the herd immunity at the same level. Right. So, COVID, if you are within first few days in the sense, first 10 to 14 days, you have a different, the phase of the disease you are in is the virus is still replicating. So in those stages when the virus is still replicating, then you can use the remdesivir, which is a antiviral medication which prevents the virus from replication. And so that is only useful in first 10 to 14 days when you are not going through a antigen antibody complex reaction. Basically what that is, the indication is that if you have hypoxia, oxygen saturation 94 or below, then you should be in the hospital and start remdesivir as soon as possible. Early it is given, the better it is. Also, if you pass that stage of 14 days, some authorities still recommend using remdesivir, but it is questionable how much it will benefit. Once you are at the stage when you are using oxygen, 94% and below is your pulse ox, and you are requiring oxygen, steroids are important part of the treatment. Now, when you are not responding to steroids, you are done with the remdesivir, and your oxygen saturation suddenly drops, then we call it as a cytokine storm, when your oxygen saturation suddenly dropped from 94 to 85 in 24 hours, and you were actually requiring 2 liters oxygen, and now requiring 15 liters of oxygen. There is some thought about checking the interleukin 6 levels at that time, but that has not been correlated with the clinical picture. So at that time, we use tocilizumab, which is an anti-interleukin 6 antibody to bind the IL-6 to prevent the lung damage to happen. There are definitely studies going on with the use of antiviral agents in the form of inhalation and oral forms, which can be, which is actually going to revolutionize the treatment as an outpatient treatment before the patient end up in the hospital. But nothing is in concrete yet. It is still, the studies are going on. No data is available which is actually useful right now to share. There is definitely a push for ivermectin in the Eastern world, but we have used it here. There's not much we found usefulness of the ivermectin. Then there is a antiviral medication from Japan, which is being used in Eastern world as well for 14 days. But I don't think there are good studies to support the data yet. So at this time, I will not, say anything about the medication which are not working, because then, how the hydroxychloroquine got the pump. So let's stay with the data we have right now.
Right. So, in summary, I think the best thing is to avoid it because the treatments are mostly supportive, and the steroid has been a game changer. Other than that, it's vaccination, and not to get it is your best bet.
Yeah, I will definitely do anything to not get COVID, because once you
Yes.
get COVID, we don't know the long-term problems which you will be seeing with the COVID. As you see, long haulers, we are calling them long haulers, brain fog, generalized weakness, chronic fatigue syndrome,